So good afternoon. We have today our second lecture from our cycle for palliative care, and I would like to introduce our speaker, Dr. Olga Kozyreva. She is a medical oncologist from Dana-Farber Cancer Institute. It is in Boston, the USA, and I'm very happy to have such a speaker and to deliver the lecture for that really very important topic. So our topic lecture, pain management, will be split into two. And today we have the first pain management lecture. So please, dear Olga, we are happy to have you and to host you. You're welcome.
Thank you, Oksana, and thank you for your kind introduction. I'm happy to be here and present my talk on pain management. I think this is a very essential part of medicine. It's important. It's important across the medical specialty. It can be related to cancer pain. It can be related to HIV, neuropathy. It can be related to postoperative pain. Some of the pain principles and goals are universal. So today we try to learn about epidemiology of cancer pain, and today I will give you pain management recipes that probably universal. So we discuss about barrier to pain management, pain evaluation, types of pain, World Health Organization pain management ladder, and opiate side effects, and then my next lecture, it would be more pharmacology. So let's talk about epidemiology of cancer pain. Cancer pain is pretty common, and I put here 4 graphs and pies, try to explore what percentage of pain patients have depend on the cancer stage. And you will be surprised that 33% of cancer patients who cured from the cancer and was treated with curative intent, after treatment, they still have some degree of pain. And I can tell, based on statistics prior to the war in Ukraine, we have 1.4 million patients with cancer, and about 179, 180 patients was diagnosed with cancer every year. And many of them treated curatively. And if you can imagine, you calculate, there is 500,000 of patients who cured from cancer and have some degree of pain. And this pain frequently underreported, and sometimes it's undertreated. And so another category of patient on current anti-cancer therapy, it can be chemotherapy, it can be radiation, it can be surgery. 59% of these patients have some degree of pain. So, and talking about advanced or terminal metastatic cancer, 64% of patients with advanced or metastatic prostate cancer suffer from pain. So, in terms of breakthrough pain, it's a very specific type of pain. Sometimes we call this paroxysmal or spontaneous pain. It's somewhat challenging to treat because sometimes you cannot find what triggers this pain. About 95% of patients with advanced cancer can experience paroxysmal or breakthrough pain. So, and I put here what is the most painful cancer by type. Majority of patients with bone cancer, it can be primary bone cancer, such as sarcoma, or secondary bone cancer, bone metastasis. 80 to 90% of this patient group experience some pain. So head and neck cancer, mouth, cancer of the mouth, oral cavity cancer, also very painful, about 80 to 90%. Genitourinary cancer, gynecological cancers, kidney cancer, bladder cancer, also have a very high prevalence of pain, up to 65 to 80%. Breast cancer patient population, with historically it's relatively big. The 50 to 55 of them has some degree of pain. Lung cancer, 40 to 50%. And less painful cancer, it's lymphoma and leukemia, 5 to 10% and 20 to 25%. And frequently these patients die from bone marrow failure rather than they die in pain. So that's also very important topic. It's universal. This category of patient have a high risk to be undertreated for pain. It's absolutely universally. It does not. It's not depend what country you are, and it's well reported that elderly, mentally impaired, a patient who has history, alcohol disorder in the past, or drug use in the past or present, HIV patient that sometimes overlap with history of alcohol and drug use disorder, nursing home residents, homeless patient, a patient who does not speak native languages, minority and prisoners, they have a high risk pain to be undertreated. And my main worry when I see this patient population to make sure that I not undertreat them, they need more pain and more careful assessment. So, and also you will be surprised that usually women tends to have more undertreated pain compared to males. So after working with cancer patients and see them in a different setting, I came up with this pain management recipe. And this pain management recipe is pretty simple. And I would like from my lecture, if you remember this recipe and try to use this recipe, that we can help more patients with pain. So this recipe is pretty simple. The first ingredient is compassion. You have to feel and respect patient pain, and you have to trust your patient, because if you don't trust your patient, it's pretty core value relation between physician and the patient. Yes, sometimes we see patients who not always honest about pain, but overall, it's very important, and I presume that all my patients who report pain, they do have pain. So common sense, very important ingredient. And you don't need to be a nurse, you don't need to be a physician, but common sense, difficult to teach. Some people have inborn sense of common sense, but common sense is not too common, and I feel it's important to give example what can be done. So a pain evaluation and re-evaluation also is important, and careful evaluation require in order to increase your chance to treat the pain and be successful. And so knowledge of pharmacology, anatomy and physiology, absolutely essential. But I can tell that now medical education changed so much. If I don't know something, right, I will go to UpToDate, I will go to guidelines, and I can get this information in 10, 15 minutes. If I need to convert morphine to oxycodone or fentanyl to methadone, it will take me tiny amount of time, but if I don't have compassion, if I don't try to help the patient, my knowledge would be useless. So I will try to give 3 examples and review 3 cases with you. And so it's real cases, and it's still, I remember this patient very well. So I had a 66-year-old woman who presented with facial pain and facial swelling. And she was diagnosed with maxillary sinus mass. And you can see, obviously, that her left sinus obliterated by the tumor. You can see a pretty sizable asymmetry, right? Her face is swollen. You can see this on MRI. And her mass invading her orbiter. And try a lot of, and her patient has a lot of swelling around her eye. So patient had a biopsy of sinus mass by ENT, ear, nose, and throat specialist. A week ago, prior she sees me, prior to see medical oncologist. She came to me crying because she's not able to sleep for 1 week. Biopsy was extremely painful. She reports orbital pain. She reports severe headache. She reports left facial swelling, eye protrusion. She's not able to sleep and not able to function normally because of pain. She was recommended by ENT specialist, take Tylenol, 300 milligram a day. So my question is, what is wrong with her pain management plan and what component from the pain management recipe was lacking? So what do you think?
May I? I think she had the complaint with problems with the sleeping. I don't see anything for sleeping here. I mean, just the paracetamol, Tylenol, and that's all. And I'm not so sure that Tylenol, even 3,000 milligrams, it's enough. That's another type of pain.
Oh, absolutely. It's clear not enough for this degree of pain, right? Yeah. And she is not sleeping because of pain, right? She loves to sleep, but she cannot because it's real bad cancer pain. So, and I can imagine that ENT, ear, nose, and throat specialist, he knows that her MRI looked horrible and her exam looked very painful. Even without the case, looking on her imaging, we know that it would be painful. So, and I went after ENT and I told, listen, do you have a license? Can you prescribe her something more than Tylenol? Basically, what I do think this is compassion is lacking, right? And the doctor tried to push this away, and he knew that this patient will see me in 1 week. And there is common sense. If patient will see oncologist who is right away jump and start manage her cancer pain with opiates. So she will be suffering from pain within the whole week, and she was not able to sleep. And she coming in a pretty bad distress on top of severe pain and symptoms. She just got very bad cancer diagnosis. So, and I think her suffering could be prevented from the start. And we have medication available, and if we see each other and we do Zoom presentation remotely, I'm 5,000 miles away. We have morphine, like a basic, in country, regardless where you are, you have basic pain medicine. I mean opiates. This is clearly not enough. So let's talk about case number 2. So I have a patient, 72 years old, with metastatic prostate cancer, and you can see his imaging. So he has a lot of disease in his bones and a lot of disease in his spine, in his pelvic area. He's coming to see us in clinic every 3 weeks for chemotherapy. So he's at home, he's taking Tylenol, acetaminophen, and oxycodone as needed. His wife is driving him because we're not allowed to drive a patient who is taking opiates. And he's coming from rural area, relatively rural area, drive about 45 to 60 minutes. So, and he's coming to my clinic and reporting severe pain, 9 out of 10, and his pain located in low back and in his pelvic area. So, and he's telling that pain usually provoked by driving and by bad bumpy road. So, and what would you recommend to this patient? Wear or use back support or brace when he's in the car and when he's driving. Take pain medicine 30 minutes prior to travel. Increase his pain medicine dose prior to travel, or all of above. So what do you think?
Seen all of above, and we can use also adjuvant therapy, especially Zometa, for mineralization of the bones.
Yeah, absolutely. I 100% agree with you. We can use Zometa because it can improve bone pain. We can use sometimes radiation if it's specific area of the pain. Sometimes we can use steroids. So, but also I feel this is common sense, right? You can tell, can you get some belt or can you have a brace or a back support when you're driving, right? Or can you take extra oxycodone with Tylenol before you come into the clinic, right? So, and I think that's important, and it's very, very simple. It's a patient education, and you educate his wife, you educate him what else can be done. Yes, we can do adjuvant, and the second part of my lecture would be about adjuvant treatment because that's a standard approach to cancer pain. But kind of to work with this pain, you can have some rationalism, like to advise patient to put some compress or to do very simple measure. And I feel it's patient education very important, and also nursing role in this extremely important. And I feel that nurses are patient angels. They're working closely. They can observe small changes in patient behavior, patient mood. The physician tends to concentrate on the medical part of this because we're overwhelmed with data, we're overwhelmed with treatment plan, the complex chemotherapy regimen, review the imaging. So, but I feel the nurses can have a major role and advocate for patient if patient pain is undertreated. So here, right, we can use common sense, we can use some knowledge of pharmacology, we can use adjuvant treatment and evaluate his pain every time when he's leaving. When he comes to the clinic, you can ask, did you take your pain medicine before you came? You can sometimes, when I anticipate that patient will drive and it would be traffic, I give him pain medication in a clinic to make sure that he's comfortable on his way back home. So another case, very interesting, and I learn a lot from this case. So I have 65 years old woman who presented with weight loss and painless jaundice. And she was diagnosed with head of the pancreas adenocarcinoma. So, and biliary stent was placed, her bilirubin was coming down nicely. We had biopsy done, and suddenly patient developed severe left upper quadrant pain. So they call me on the bedside, and they don't, the internal medicine team on the floor are not sure what is going on. Patient in severe distress, A, because of pain, B, because of just pretty serious cancer diagnosis. She's crying and she's totally convinced that she's dying from advanced pancreatic cancer. So when I examined her, I was puzzled. So she presented with painless jaundice, her pain and tenderness actually on right upper quadrant, and it's painful for her to take a deep breath. So, and I went downstairs to radiologist, and we review with radiologist what was going on the most recent imaging. And you can see on the right screen, she was diagnosed with splenic infarction due to splenic vein thrombosis. And we started IV heparin together with pain management. Yes, she was on IV morphine, but her pain resolved because her pain was not related to pancreatic cancer. It was related to splenic vein thrombosis, and treatment was totally different. So, and in this case, what is important, right? And I think in this case, you guys can comment what we use in this case from the pain recipe. Compassion, common sense, evaluation, re-evaluation, knowledge of pharmacology, anatomy, and physiology.
I think re-evaluation, yes. What's the most important, because we had another reason for pain.
Oh, I totally. Sorry.
Systemic thrombosis are very typically for cancer. And we have often complication, systemic thrombosis. And maybe in this case, acute pain increasing on the pain in patients may be induced by thrombosis, because after prescription of the heparin, maybe fraxiparin, enoxaparin, and other anticoagulants drug, we have decreasing of the pain, because ischemic pain is very strong.
Yeah, I totally agree. And I think careful evaluation, right? Patient exam and knowing of anatomy, because head of the pancreas mass, she initially presented with painless jaundice, right? So, and suddenly she has acute event. So, and it did change her management. Of course, she received pain medication, because any ischemic pain, like heart attack, right? Any bowel ischemia can be very painful, or limb ischemia, you know, leg ischemia is very painful. So, I also would like to tell you that not all pain in cancer patients are cancer related. And I would like to remind you that pain in cancer patients can be not limited by cancer, but also can happen due to acute cholecystitis, diverticulitis, appendicitis, kidney stone, zoster, compression fracture due to osteoporosis. This is pretty common. You have patient with prostate cancer, or you have patient with breast cancer, and frequently they have osteoporosis, and they can develop compression fracture, non-metastasis related. And this can be in the same area when they have metastasis. The treatment of pain would be somewhat similar, but it requires careful investigation and explanation to the patient. No, this is not cancer pain. Your disease is stable. You develop compression fracture. We will deal with it. So pulmonary embolism, one of the pretty frequent complication of advanced malignancy, and it can be very painful because patients develop lung infarct, right? They can develop pleuritic pain. So patient with cancer can have heart attack with typical heart attack presentation, and this patient can have metastasis to the ribs, metastasis to the sternum, but they still could have heart attack and pain radiate to the left arm and shoulder, which is classical presentation for heart attack. And so, point I would like to make, always evaluate new pain and do not presume that this is new pain secondary to cancer. I had a couple cases patient with liver metastasis who developed acute cholecystitis, they were treated for cancer pain because people presume if patients have liver metastasis, they have cancer pain from this metastasis. A lot of time, if it's parenchymal metastasis, is not pushing liver capsule, liver metastasis, even big ones, they can be painless. So, okay, and now I would like to talk about common myth and misconception about pain. It can come from doctor's side or nurse's side. In the United States, we call this providers, healthcare providers. I don't like this. I still prefer to call nurses and doctors or physician assistant rather than providers. So sometimes we believe that too much pain medication will result respiratory depression and can or will hasten patient death. And according to physiology, the pain stimulate respiratory center, and it's hard to have respiratory depression when patient in severe pain. So also there is misconception that pain should be treated rather than prevented. We just discussed the case that some pain can be prevented successfully, and important to prevent pain, anticipated pain. For example, patient started physical therapy. Regardless of whatever pain from arthritis, from cancer, neuropathy, we know that it's a high chance that pain will go higher and increase with physical therapy. I asked nurse on the floor, can you give pain medication 30 minutes prior to start physical therapy? Or if my patient needs to go to radiation, we know for compression fracture of the spine, yes, on steroids, yes, on patient already getting opiates, but I will ask nurse to give extra pain medication before patient travel to radiation oncology department, because it would be painful for the patient, A, to go to the stretcher because it requires extra movement, to go from the stretcher to radiation table and go back, right? We can anticipate that patient will be in pain and we can prevent the pain. And so some believe that patient will always report pain to their doctors or nurses. Not necessarily. Some of the patients would like to be stoic and they feel that reporting pain, they would be weak. That frequently can happen to the stoic guys, and a lot of time it can happen on some certain ethnic patient with ethnic background. I know that patients from Asia try underreport the pain, and I spent extra time with them. So some of us, doctors and physicians, believe that patient will show sign of pain. Again, it's not necessary. Patient can be very stoic and can try to hide their pain. I remember one case that I was treated a patient with prostate cancer with docetaxel. He was doing well, his PSA was coming down, and it was only one medication kind of worked for him. And he told me, I'm doing fine. And I met him in the hospital hallway, and I can see that he was touching the wall, and he was in pain when he was walking. And then I realized that he has severe neuropathy, and he's trying to hide this neuropathic pain from me in order to continue docetaxel. And he always sitting in front of me in a chemotherapy chair and tell, I'm fine, excellent, I feel great, let's do it. So same, it's happened to oxaliplatin a lot because, and Taxol a lot, this medication that's essential in some of the cancer, and patient can realize that you can decrease the dose or discontinue if they report pain. So some of us believe that frequently patients overestimate and exaggerate the degree of pains they experience. And pain is very subjective, and we do not have measurement of the pain. Yes, we have we have scale we can use, but still the trust is essential. I remember one of the most difficult pain management case in patient who is active heroin users, and he is 35 years old with metastatic penile cancer with metastasis to the skin, up to the back, and basically destroyed genital area, fungating mass. So, and he was using heroin up to 2 grams a day. So, and of course his pain requirements was pretty high, and the team taking care of this patient on the floor, they just not feel comfortable to give him pretty high dose of hydromorphone. So, and of course, patient had the stigmas that he's a drug abuser. We end up transferring patient to intensive care unit. We end up to get anesthesia and palliative care involved, because even pharmacies, they not feel very comfortable to give such a high dose of pain medication to make him comfortable. And so, and another misconception that pain is unavoidable aspect of having cancer, it's wrong. I usually tell my patients that we're able to reach adequate pain control with all tools we have in about 95% of the patient. But definitely we can decrease pain, maybe not from 10 to 0, but to acceptable level of 100% of patient. So there is also some misconception and barrier from the patient side. And again, this is variable and depend on your patient population, patient ethnicity, cancer, what is available for the pain management. So a lot of cancer patients try to not take too much pain medication, because when they think that if the disease progress, they will start really bad pain, that medication will not work anymore. That's not true. We have enough morphine, we have enough pain medication to make them comfortable, and there is no kind of ceiling for the dose of pain medication. Patient will get pains they need for their pain and to be in comfort. So some of the patients think that taking pain pill means that I'm a weak patient. So very common patient telling me, I will get addicted. And there is no scientific data, especially patient who has metastatic or advanced pain, that they will get addicted. Patient who treated with curative intent, especially young patient had a neck cancer, which treatment pretty painful. Patient with gynecological cancer, cervical cancer. So we talk to them that we are planning to decrease your pain medication when we get you through the treatment, when we get pain under control. I have couple patients who developed physical tolerance and who developed some sort of, we call this chemical coping to the pain medicine. We had open discussion, your cancer is cured, we're gonna treat you comprehensively, we will try to tape off your pain medication, because we cannot see you taking pain medication for prolonged period of time after your cancer is gone. So it's pretty time consuming, but the goal is of pain management that they in comfort and have at least pain medication with maximum functionality. So Sometimes the statement, I will get addicted, this is part of denial, right? It's been, sometimes I see patients in severe pain, life expectancy several weeks, and they tell me, I will get addicted to the pain medicine you're giving me. No, he or she does not time to get addicted because time is short and life expectancy is short, but in patient view, he or she has a time, and the statement, I will get addicted, it's part of denial and non-acceptance of cancer diagnosis. And so some of the patient believes that nothing can be done to relieve cancer pain. And again, it's not true. Majority of country now have enough basic pain medication. Yes, and I understand the bureaucracy, how you prescribe this pain medication, and it takes extra time, extra steps, extra documentation, but we able to provide this. So, and another misconception from the patient, when I feel pain, I should hold off as long as possible before taking medication. It's easy to prevent pain and treat pain when it just started, rather than patient in really bad pain and instead oral medications, they need IV medication. So patient education, how to handle the situation, it's really essential. In US, we do have a problem with opiate addiction, and it was very aggressively addressed on the governmental level. Some of this addiction started due to prescription. Majority of prescription was for chronic low back pain, toothaches, headaches, like non-cancerous pain. So, and it was pretty good project how they did it. And now we have a special system, almost like you log into your bank account. I log into my pain management account, and I can send prescription through my cell phone and put a pin within 3 to 5 minutes, and I don't need to document, but I need to check patient previous prescription to make sure that they not, we call this physician shopping, they're not going to different doctor to get pain medication. But I feel lucky enough that I don't deal a lot with people who is drug seeking, because my patient population is cancer patient, and maybe I have a couple of them who is actively using or who have a history of drug use disorder, and now they coping with pain medication, with anxiety. I'm very glad that government supporting us and healthcare supporting us and makes this easy for us to document opiate prescription, and it's easy for the patient. So when I see patient with pain, we talk about affect pain on our body. And if poorly controlled pain, undertreated pain, it can cause weight loss because its nature suppress your appetite. It can cause anxiety, depression. It can cause sleep deprivation. It can cause existential suffering. So, and I think that's very important to prevent, and it's essential part of any doctor or nurse job, and that's why we went to medicine, to prevent and help people who are suffering. So we also talk about an immunologic side effect of undertreated pain. We know that if patients have untreated pain, undertreated pain, this is very stressful for the body. It can cause a constant release of cortisol, stress hormones. So, and in the end, it can decrease your immunity and decrease cytotoxic immunity of natural killer cells. Sometimes this explanation that it can decrease your immunity works pretty well for the patient. So when I see patient with newly diagnosed or worsening pain and planning to start opiates, we usually we usually tell the patient that opiate side effects, highly predictable and highly manageable. So I do expect that patient will get constipated. And I do expect the patient when will start a relatively high dose of opiates, they could have some degree of sedation until we achieve stable concentration on opiates in the blood. So some patients have less constipation and less sedation. Some patient needs just prune juice for constipation. Some patient needs 4 pills of senna. So everyone is different. There is no universal recipe, but we have to let them know that this is expected and manageable side effect. So especially when we start medication, opiates, nausea can be seen. Again, manageable, somewhat expected. Some pain medication have more nausea provoking versus less nausea provoking. And this is not allergy. Sometimes we need opiate rotation to see what opiate group works better for the specific patient. So pruritus or itchiness is pretty common, especially for patients who starting morphine. It's usually related to histamine release. Can be unpleasant for the patient. It's very preventable. Patient can get Benadryl, Dimedrol, oral or IV if they have pruritus. So urinary retention can be seen in elderly guys with big prostate. Some opiate can cause urinary retention, and before discharge, usually nurse make sure that they're able to urinate before they go home or they transfer to another facility. So pain evaluation. About 40 years ago, pain scale was invented, and now in the United States, it's 5th vital signs. We have 4 vital signs: heart rate, respiratory rate, blood pressure, and heart rate and temperature, right? And now we have to document a 5th vital sign as a pain. So this is mandatory, and I usually get a call from clinic assistant who is just checking vital sign if my patient have pain more than 5, and they text me, Dr. Olga, your patient is in pain, what would you like me to do? And I will tell, okay, talk to the nurse, and nurse go and assess the pain. So when I go inpatient and I have inpatient round, I open my computer system and I can see what was the fever, what was blood pressure, and what was the pain, right? And I can see that pain was taking 4 times a day or more often if pain is more than 5, and documented response to the intervention, pain medicine, and I can evaluate. So now we have about 11 types of pain scales. So we use in real life numeric 1 to 10, that it's 0 is no pain, everyone is happy and comfortable. So, and 10 is the worst pain possible. So it's comprehensive, majority of patients able to understand. But another scale we use for patient who is not able to understand numeric, and we have to remember that children, people with patient with cognitive impairment, non-native speaker, hard to understand numeric scale. We use 1 Baker scale faces. So, and I put here, and it's pretty comprehensive and easy to understand, and it's printable from internet. It's also, you can see in Ukrainian language, and it's printable in any languages. We have so many different ethnic background patient, and it's easy to Google and put this in Vietnamese, and we have usually laminated card with pain scale Baker faces on the different languages in every patient row. So another important tool you can do, you can use pain diary. And pain diary is the most accurate self-assessment tool, and it can be printed. It can be printed from internet, and there is several applications exist, and some, a majority of them actually for free and probably supported by a pharmaceutical company. So basically you ask pain to grade the you ask your patient to grade the pain and put numeric scale, and you can put you can ask them to put the timing, and you can ask them to put and document what did they do when they measure the pain, and you can ask them to document the pain, what type of pain they have, burning or you know, sharp pain, radiated pain, and you can ask them to document what did they take during the pain and how the pain responded to intervention, right? And intervention can be taking Tylenol, can be taking oxycodone, morphine, can be a heating pad, you know, or cold compress. So, and then you can evaluate this together with the patient and try to understand the pattern and try to do intervention, because sometimes you need to give pain medication before bedtime if patient consistently waking up 2 a.m. and need extra dose of pain medication. And so, and again, it can be used also known for non-cancer pain. It can be used for migraine, for fibromyalgia, for neurological disorder, for neuropathy, helpful. So pain assessment, it's relatively straightforward, and it's probably you all know already. Location, onset and duration, character of the pain. You will ask patient, tell me more about your pain. Is it sharp, dull, burning? Pain intensity, right? This is where your pain scale is important. You will grade the pain. So you will ask patient about what makes your pain worse or what makes your pain better. And sometimes I'm totally surprised when patient with severe cancer pain telling me, oh, you know, the warm compress is really taking my pain away. Yeah, hard to believe, because, and you kind of start thinking what's the other component of this. So sometimes patients telling me, yeah, my pain relieved by benzodiazepines, and I kind of getting, yes, this pain mixed with severe anxiety, that's why benzodiazepine relieve pain. And so very important point, I usually ask if they have experience with any opiates in the past and what did work in the past. So, and you will save, with this simple question, you will save a lot of time for you, and you will have a very high patient satisfaction, and you develop trust. If patient is telling me the hydromorphone in the past worked better for me, I would not start with morphine. I don't see the point if patient suffering from the severe pain, why I have to let morphine fail or morphine cause severe nausea, or it's not enough for this patient, if patient telling me what was working in the past. But of course, this is when pain medication is easy to available, because in some setting in different country, you guys sometimes not have enough pain medication. We have all array, and I can use whatever I want. So we also have, as you know, opiates is working through the mu receptors, and we have mu receptors heterogeneity, and some people can have a different genetic pattern of this mu receptor. Some patient can be fast metabolizer, some patient can be slow metabolizer, and some patients have more pain, more nausea and oxycodons, some patients have more itchiness of morphine. We all differ. And so, meaning of pain to the patient. Of course, it's a lot of emotional component to the pain. It can be associated with anxiety, depression, existential suffering, right? Yes, labor pain and post-labor pain can be very severe, right? But when you see the happy woman with just newborn baby, her pain have a totally different emotional component, right? Compared to patient with 2 small children who is dying from metastatic breast cancer, right? Pain can be very severe in both cases, but emotional meaning is totally different. So important to ask about history of chemical dependence. Here in US, majority of people pretty open to it, and they can tell, yeah, I former drug abuser, I former alcoholic in recovery. My last drink was, I'm like in sober, my last drink or my last heroin use was 5-10 years ago. So, but it can tell me that I need to be more careful, do not undertreat the patient because the requirements can be higher. And kind of the requirements can be high, and they can develop chemical coping when they're taking pain medication, not only for pain, but also for emotional issue, depression, anxiety. So we also have to be aware when your patient telling you, I'm always 10 out of 10, why it's happened. So usually this is 3 potential reasons to it. Mood disorder, depression and anxiety, they always 10 out of 10. Cognitive disorder, dementia, or they're not able to understand what are you asking. They can be in discomfort, 10 out of 10. The situation can be 10 out of 10, and I usually talk to them that it's sometimes difficult to split between physical pain and emotional pain, and takes time and careful assessment, but possible. Another reason for it, somatization, right? The patient transforms the distress and global suffering into pain and symptoms expression. So types of pain. Also well known, acute, chronic, breakthrough, or paroxysmal pain. Pain can be somatic, burns, fracture, wounds, musculoskeletal pain, right? Arthritic pain. Pain can be visceral due to organ obstruction, due to stones, kidney stones, gallbladder stones, right? Angina, ischemic pain, pancreatitis, invasion of the organ, liver capsule pain, right? Pain can be neuropathic, and neuropathic pain can be due to HIV, can be due to neuropathy, secondary to chemotherapy. Patient already cured, still have neuropathic pain, spinal cord compression, plexopathy. A lot of pain mixed. It's mixed between neuropathic, somatic, and visceral pain. For mixed pain, frequently we use adjuvant treatment. As you know, gabapentin, neurontin, great for mixed pain. Tramadol is great. Methadone is great for mixed pain. So pain can be referred. We know from internal medicine which pain can be referred to what area, right? And we know that heart pain can be referred to left arm or jaw, and gallbladder pain can be referred to right shoulder. Sometimes left lobe of the liver can be referred to left shoulder. So in special kind of area, it's cancer pain syndromes, specific syndromes related to cancer or cancer treatment in a specific area, and it's about 30 of them. If you know anatomy, and it's good to know that disease syndromes, and usually we help this with systemic treatment, and interventional radiology can help us to manage this pain. And so, and this is my last slide. About 35 years ago, World Health Organization created very simple and efficient tool for the pain management. It's called HWO pain management ladder. So originally, this had 3 steps. Now it's 4 because interventional radiology and interventional treatment are more available now. When we use a simple tool, we able to get patient pain under control in 70 to 80% of the patient. This pretty easy and simple. 4 steps, and first step, when patient experience mild pain, we use non-opiates medication plus some adjuvant treatment, and I will go in detail in my next talk. And if patient is not responding to intervention for the first step, we will advance and we will use weak opiates plus non-opiates and plus still adjuvant therapy. And if it's not efficient intervention, we'll go on the next step. We will switch weak opiate to strong opiates. We use non-opiate medication, and we use adjuvant therapy still. And if it's patient still in severe pain and suffering, we will add on interventional pain treatment that can be systemic or can be like intrathecal pump or can be local like a nerve block. So I finished now, and I'm happy to take your questions.
No, thank you very much. It was very interesting. Really, I just realized that I'm also very biased.
Olga, thank you for your lecture, but I have one small question. We have a small problem in Ukraine. We haven't any hydromorphone, yeah, in Ukraine. We haven't now codeine tablets. We haven't now hydromorphone. We had hydromorphone, especially brand name Dilaudid.
Dilaudid.
Yes. At last, by have not this drug, no. We can use only tramadol, synthetic opiate tramadol, and buprenorphine, and oxycodone, and morphine.
Yeah, I mean, yeah, basically you have 4 medication, right? And kind of try to figure out what's the best. You know, morphine is a good medication used for, you know, morphine was used for 3,500 years. 3,500 years, a matter of the dose, right? If you do morphine IV, if it's, you can receive adequate pain control, plus you can use your adjuvant, right? We usually, like on day-to-day, we use hydromorphine, we use codeine, oxycodone, we use buprenorphine, we use fentanyl. So we use hydromorphone.
I like the fentanyl in the patch, but we haven't this patch now in Ukraine also.
Yeah, but that's great. We fentanyl patch you use for chronic pain, right? If we're talking about acute pain, right? Pain crisis, you use morphine because there is not much you can do in terms of IV medication. You use morphine, and if you anticipate that pain will last and it's chronic issue, you can start fentanyl patch almost concurrently, small dose, right? With your IV morphine. Yes, there is a limitation, and I think the need for modern pain management because of war, especially for chronic pain, especially for wound pain, phantom pain, it would be, unfortunately, big need, right? And we're lucky to have very sophisticated pain medicine, intranasal fentanyl lollipops that people can just, put in the mouth or spray in the nose, and pain will get away in, 5 minutes. But you have 4 pills to use, and we need to be creative. Some country has just a morphine and Duragetic patches available, but you need to pay for it. So I think it's important on a kind of institutional governmental level to create comprehensive pain guidelines from what is available now.
Olga, what is your opinion about place of tramadol, nalbuphine, butorphanol in palliative care?
So I think we use tramadol for in palliative care. Tramadol is weaker than morphine, right? And it's good for the mixed pain. It's not always good for elderly, but if you have patient, if you don't have limitation what you use, and you have diluted hydromorphone available, and you have tramadol, right? Obviously, diluted is much stronger and have less side effects. But if you don't have diluted and tramadol is available, you have to use what is available now, right? We use this probably less than like straightforward, simple opiates, but we use it. And tramadol for non-cancer pain, we use tramadol as well, available, cheap. So methadone, I don't know if it's available in Ukraine for the pain management, excellent and cheap, but probably the cheapest from all pain meds. And methadone is cheapest, the second is morphine, but tramadol has a very long half-life, and it's require knowledge how to do it, how to escalate, how to transition to methadone. And methadone not, because it's overlap with heroin addiction treatment, and it has high market value, right? People can sell tramadol, methadone. It's less popular, but still very efficient pain medication to use.
Mm-hmm. Thank you, Olga.
Sure. Any questions from students?
Students, please. Будь ласка, задавайте запитання. Якщо ви сумніваєтесь в англійській, я перекладу. Будь ласка. Які є запитання, що вас зацікавило? You are welcome.
Hello, can I make a question?
Sure.
Yeah.
Olga, I want to hear about your opinion about medical cannabis in treatment in palliative care. Yes, thank you.
So absolutely, I a certified patient for medical cannabis since 2000. Lecture about medical cannabis. I feel very comfortable. It's about pharmacology. It's lecture about medical cannabis. We're not touching recreational marijuana, right? It's cannabis. It's different than marijuana. Marijuana has a very specific stigma. A lot of my patients, we use this as an adjuvant in a lot of my patients, and it's widely available. You don't need even certification now. It can deliver to your home. It's very easy to get. So I can give you separate lecture, and I think it's very, very important to know about it, because more and more countries accept this treatment, more and more patients use it. And unfortunately, physician doesn't know what it is and how to use it. So let me know.
Thank you.
This
This would be great to hear, because recently I have heard that our government registered a project of a law about medical cannabis. So that would be great to hear about to hear this lecture. Thank you.
And I think honestly, it would be interesting research project for the student, right? To assess knowledge of the faculty and assess knowledge of the patient, how they open. And 10 years ago, I did, with my fellow, we did a project. It was very easy. We did a questionnaire, and somewhere I have a questionnaire. Before Massachusetts, what for the cannabis to be available. And it was just a waiting room of oncology office. And we easily got like 150 questionnaire from 150 patients, and we just asking, do you use it? Was totally anonymous, and then we presented. It was very, very interesting. And same, one of my colleagues did question of oncology doctors. What do they know, and how often they recommend, and it's kind of conclusion from the study that doctors not knowledgeable about marijuana, but cannabis, but they tend to recommend to use it. So, and in a lot of European countries, it's no restriction for medical use. Majority of European countries, no restriction. For recreational use, yes.
Thank you very much.
Okay, good, thank you. So I will see you in 2 weeks.
Yeah, next lecture is planned for the 1st of March. It will be a pain management part 2, but pharmacological aspect of the pain management. So thank you very much. Thanks a lot for the great lecture. It was very interesting, and we will be happy to welcome you once again, 1st of March.
Okay, bye-bye. Thank you.
Bye-bye. Thank you very much.